Welcome, Dr. Ebere, to the Global Health Uncensored.
Thank you very much. It's a pleasure to be here.
Yeah,
I'm a big fan of this podcast.
we are all a big fan of your work. I mean, you're doing an incredible job in the field. So it's wonderful to finally have you share a conversation with us. But before we dive into the broader themes of our discussion, I'd love to learn more about your personal journey in the field of global health, your experiences. Uh, I believe these will be incredibly valuable to understanding the complexities and the challenges um, within the domain. So, by way of introduction, could you share some insights into your early life and how those experiences influence your decision to pursue a career in public health?
Okay, so again, thank you for having me. It's such an honor to be on this podcast. Right, where to start? So, I was born in the UK to Nigerian parents. I was born just at the beginning of the Nigerian Civil War, the Biafran War. And because my father was in the UK for postgraduate training, and we returned to Nigeria shortly after the war ended to because my dad wanted to contribute to rebuilding the country after the war. So even though I was born in England, I all my formative years were in Nigeria. I grew up in Nigeria, what some Nigerians will recognize as an ABU, which is an Aba brought up. I grew up in a small, not that small, commercial town in the southeast of Nigeria. And my father practiced medicine there. He grew up there as a child, returned there as a medical practitioner, and he practiced medicine there for almost 50 years. He retired in his 80s. So I grew up in a household with a medical practitioner. My mother was my first feminist role model, although she would actually not identify herself as a feminist. But she was the first person to demonstrate to us that the women can occupy their space and take a leadership role in their professional space, as well as in be a homemaker and a parent and to lead the communities that they belong to. So I grew up in Nigeria, and that, as you all know, we Nigerians we grow up believing that we can do anything.
Yeah.
That is the Nigerian default position. And the interesting thing was growing up in Nigeria, everybody who did everything is black. So like Chimamanda, I didn't realize that being black was an issue until I left Nigeria. Because I knew people who were in charge of everything who were black people, Nigerians. So it was actually moving abroad into the UK for my postgraduate training via Trinidad and Tobago, actually, was the first experience of, the color of my skin is supposed to be a barrier. But before getting to then, I had already experienced the perception of women in Nigeria as being less than men. That was, like I said, that was not the experience in my home, but it was one that I came across very quickly and consistently in academia and education and workplace. So in terms of how my early years informed where I am, what I do today, I actually didn't realize that until in hindsight. When I was about 10, I believe, or a little younger, we had a cousin come to stay with us for holiday. And while she was with us, she was diagnosed with tuberculosis. And up till that point, it had never even I recognized the privilege in growing up in the family I had with the opportunities I had, because TB as something that would affect someone like me had never occurred to us. So we all had to get screened, as a contact tracing and stuff like that. And I was totally fascinated by this is medicine. You actually go to people and know where they came from and where they live.
Yeah.
It was totally fascinating. And it sort of parked at the back of my mind. And it wasn't until I was actually in clinical practice as a junior doctor in the UK, and I started getting a little frustrated about we treating patients. They're coming in with the same problems. We treat them, they go out, they come in again. And why aren't we asking about the social factors, the other factors in their lives that might influence how we prevent or how they manage their diseases? And so I started thinking, I knew I didn't want to stay in clinical medicine, but I didn't know what it was I wanted to do. And this is one of the reasons why the Liverpool School of Tropical Medicine is one of the educational institutions I'm most happy to be associated with. I went to the LSTM to do the diploma in tropical medicine and had the privilege of attending a series of lectures by Professor Adito Kombo Lucas. He's now passed, who was a professor of community medicine, as it was called at the time. And he talked to us about communicable disease control. And I went, that's it. That's what I want to do. I want to figure out how to stop, how to engage with the society and community to stop these problems that we're having. And it clicked back to that early experience with TB. And as it happened, my clinical practice at the time was mostly in infectious diseases and tuberculosis. And then I went into public health, almost obsessively focused on TB. And still obsessively focused on TB. And I think, and I always challenge people to say, if you really want to address health and health equity, solve TB, because it touches on every facet of the human existence. And the challenges of TB are the challenges of the human existence. So that's kind of how I ended up going into public health, specializing in communicable disease control. From communicable disease control, new emerging infections, zoonosis, and of course, that then morphs into health protection, emergency preparedness response, and that just sort of morphs into global health. Because I came to the view that why am I working in the UK addressing this issue? They have lots of people who can do this. I should actually refocus on my part of the world where these challenges are as significant, if not more so, but the resources to address it are less. And then, of course, threaded through all this is that experience of initially gender discrimination, and then when I was working in the UK, gender and race discrimination, or as they choose to call it these days, disparities. It's misogyny and racism. That's calling it what it is. And the underrepresentation of people who look like me in leadership positions. And again, back to TB. TB is a disease that demonstrates the challenge of equity in health.
Yeah.
And I kept thinking, so why are we trying to solve to address equity when the system is designed to maintain that status quo? If groups of individuals are not represented in shaping, designing, leading those systems, then you're never actually going to change the circumstance, the status quo, because you cannot rely on other people to always speak for others. You've got, and if there is an opportunity, and there's no reason why there shouldn't be, for everybody to contribute to the decisions that shape the systems that work for them. So that's kind of what got me to what I do today and the things that I care about. And all through that is really around equity.
Equity. Okay, I think that has been an interesting journey and motivation. Being born in the UK, going back to Nigeria, and coming back in the diaspora kind of gives you a different perspective. I always say that once you stay in any part of Africa, the way you think is quite different from those who grew up entirely in the West or in the diaspora. So that kind of gives you a different perspective. And for as a Nigerian, as having worked and being in a class with Nigerians, I always feel that I can do spirit in it, and that's one thing that I truly like about that part of being Nigerian. So thank you so much for sharing with us your journey, your passion, and how this has motivated you.